I chose to do my presentation on Thromboangiitis Obliterans, or TAO for short, also known as Buerger's disease. So TAO is a non-atherosclerotic inflammatory condition which affects medium and small-sized blood vessels in the extremities. It causes ischemia in tissue distal to the affected site, with resulting necrosis if left untreated. And there's a high correlation with the use of tobacco-containing products. There may be evidence of predisposing genetic factors. The symptoms usually occur between ages 40 to 45 and include Raynaud's phenomenon, migratory phlebitis, ischemic ulcers, and neuropathy. So TAO is a type of vasculitis in which the elastic lamina is preserved and a highly cellular thrombus develops. It's characterized by migrating phlebitis with intermittent segments of normal vascular tissue, and there exists a high correlation between the use of tobacco products and the incidence of disease. It's more prevalent among men than women, particularly young men, and it may be linked to poor oral hygiene. A 2005 study found that 93% of cases had oral bacteria DNA present in arterial lesions by PCR. So the physiology, while the etiology of the disease is not well understood, in the acute lesion phase, inflammation and thrombus formation occurs due to the body's response to either bacteria or a protein in tobacco products. Cell infiltrate appears, as do leukocytes and microabscesses around the thrombus. And as thrombi become lodged in capillary beds, occlusion of blood flow leads to tissue death distal to the blockage. It's been found that patients with TAO have an increased sensitivity to type 1 and 3 collagen, suggesting there may be an autoimmune factor in the predisposition to the disease. But purified tobacco glycoprotein may be the cause of changes in vascular reactivity, leading to inflammatory small vessel occlusive disease. Anti-endothelial antibodies elevated in 25% of the patients suggested a possible immune response to antigens in tobacco, according to a study in 2009. So there's several ways to diagnose this. Migrating phlebitis in young patients is very unusual and is suggestive of TAO. Claudication starting in the arch of the foot is an early sign of the disease before it progresses, and actually may be specific to TAO alone. There's a test called Allen's test, which by placing pressure on the radial and ulnar arteries of a patient's hand and then asking them to open their fist, releasing the pressure off the radial artery. If the blood returns to the hand, it's a negative test for occlusion, and if it remains pale, it indicates that there's an occlusion somewhere. Angiography with contrast helps visualize occluded blood vessels and is very useful. And then other qualitative tests to rule out similar conditions can help narrow it down to TAO. So here's a few pictures of what can be expected to be found on angiography. On the left is our aortic arch, and our left subclavian artery you can see has thrombi in it, as well as the right brachiocephalic artery. And then to the right is a picture of a patient's hand where his thumb, index finger, and middle finger are severely occluded. There's hardly any blood getting through there. And then these next couple pictures just show what a normal angiogram looks like compared to that of somebody with the disease. So for the disease course, there's kind of three grades of lesions. So in the acute phase, inflammation of vessel walls involving all the layers is present, and then it's mostly in the veins with accompanying occlusive thrombi, and there's often polymorphonuclear leukocytes and karyorhexis microabscesses around the thrombus site. Then when you have intermediate phase lesions, the thrombus progresses with more cell infiltrate, and there's more arteries and veins. More arteries are affected now, with the phlebitis migration becoming more evident. The elastic lamina remains intact with lessening inflammation, and claudication if it started in the arch of the foot, has now usually progressed to the calf and more general leg pain, with the lower limbs being mostly affected by this. And then the chronic phase lesions have or characterized by extensive recanalization, prominent vascularization of media, and adventitial and perivalvular fibrosis. And then sites distal to the occlusions become ischemic, and if untreated, necrose and die. Throughout each stage, there's segmental inflammation with areas in the same vessel containing normal wall tissue and others with affected tissue. And the degree of vascular wall distribution with inflammation is more than typical for aging and may be of varying degrees within the same vessel. So treatment primarily includes quitting smoking. There are some drugs that allow patients to walk longer distances without intermittent claudication, but that just is helping manage the symptoms of the disease and not cure it. Really preventing the smoking, which has been linked to the inflammation, is the only way to improve it and to treat it. And in severe cases, there are some surgical interventions that can be had. The prognosis is pretty good. As long as the patient stops smoking, it should take care of the problem. But if they don't, then that's going to cause increased necrosis with a series of amputations being required.